the Bald Oncologist Podcast Series, featuring Dr. Malwinder.
Hello everyone, welcome to the Bald Oncologist Podcast Series. We are in the month of October and our episode for today is going to be about breast cancer. So in our studio, we have Dr. Saladina. She's a consultant breast surgeon. Okay, so Dr. Saladina, so we'll be talking a little bit about breast cancer right now. So what are the initial signs and symptoms which patients normally present with?
Normally, it's actually they present with a lump in the breast that is often painless.
Okay.
A lot of patients think when they have a painful breast, they worry about cancer. But on the contrary, when it's a painless lump, that is more worrying. And I think the key points is if you feel that the lump is fast growing, feels very hard and quite fixed, the breast, it's something that needs attention.
Okay. So how do a patient normally go for breast cancer screening in Malaysia?
Generally, you can go for mammography and ultrasound. A lot of centers provide these services, especially in the month of October. Most hospital, in private hospital or government will have some offers and packages for women.
I think there's a lot of NGOs support that also.
Yes, definitely.
Yeah.
For women generally 40 and above, we would advise for mammography. And because a lot of women, Asian women in general, have dense breast, it would be best to couple it with an ultrasound breast. So,
okay. And what is the difference between mammogram and ultrasound?
well, one is an X-ray, which is mammogram is basically an X-ray of the breast versus ultrasound. You use ultrasonic wave to diagnose lesions. So they look at ultrasound, will look at consistency of the lesion. So these two tests complement each other in a way. When you do mammography, you will look at density of the tissue. You will be able to pick up calcification changes, which are often the very early signs of breast cancer. This happen even before the lump is formed. So if you catch it at that point when it's only calcification, you can actually treat it easily. Curative is very good. You probably don't have to go to the whole panel of treatment like chemo and all that. It's early
because
stage.
it's really early.
Yes. So, but when you have very dense breast tissue, the ultrasound, on the other hand, complements the test by allowing us to see more detailed breast image.
So can someone substitute ultrasound with mammogram? Because some of my patients say mammogram is very painful.
No, I mean, you can't substitute ultrasound with mammogram because it's different tests altogether. Yes, no doubt, mammogram does have a little bit of discomfort when it comes to compression, but with the newer machine, the new digital machine, the tomosynthesis machine, it is not as bad as those days. So the compression is actually not that bad. So must try it before then judge it for yourself.
So can a male person go for a mammogram because we don't have breast issues?
Generally, for men, it will be more uncomfortable to do a mammogram. And if we see a male patient with suspicious lesion in the lump, we in the chest wall, we will send for an ultrasound.
Okay, so what about like some patients who are like high risk of genetic disorder like BRCA, where there's high risk of getting breast cancer? Is there a different way of screening for them?
For BRCA gene mutation patients, they often present younger age. Doing mammography may not be the best tool because you won't be able to see and get more information from the dense breast. So MRI is one way to screen this group of women.
So they do it every year or like after many years?
Recommendation is yearly, but having said that, MRI is not cheap.
Yes, that's true.
It's not cheap. So because of that, we don't routinely send women for MRI screening in this country.
Okay, what about ultrasound mammogram? Like you mentioned, more than 40 years. Is it yearly, 2 yearly?
Okay, mammogram for screening population. Screening means you're completely well. You have no risk factor. So it will be 2 yearly for mammography. Ultrasound would be once a year. If we find something, or else it will be a 2 yearly mammography. For younger women who wants to come for screening, or those women who have risk factor, maknanya ada family history, mom with breast cancer, it would be better for them to come earlier. I would say 10 years before the age of diagnosis of the mother. For example, if your mom has breast cancer at 38, but she doesn't carry the BRCA gene mutation, you can start screening as early as Yeah, as early as in your late 20s with an ultrasound breast.
Okay.
Apart from doing your self-breast exam every month, that's something women can do even in their teens.
They can check when they're
They
going
can
for a shower and all.
Yes.
Okay.
1 month. Every time once a month.
Once a month. Okay. So, if a patient is diagnosed of a breast lump, okay, so what are the kinds of surgery which a patient can go for?
It depends what is the diagnosis of the lump.
Okay.
So generally when we see a patient with breast lump
Okay.
coming to us, we would do a triple assessment a procedure. Yeah? So that triple assessment consists of examination, imaging tests,
Okay.
and a biopsy.
Okay.
Normally the last test, which is the biopsy, is warranted if the imaging features of the lump as well as the clinical examination is suspicious of cancer.
Okay.
Once biopsy is done, you will see the result. So kalau the biopsy result comes back as non-cancerous lump, then the treatment would be 2 options. I generally advise patient for a monitoring protocol.
Okay.
If it's a small lump, for example, a 1.5 centimeter fibroadenoma, you don't need to excise it.
Okay.
Yeah, but these women needs to be monitored. So the monitoring would be every 6 months first, and to monitor the size and the growth of these nodules.
Okay.
If it's stable, then you can actually see them yearly as part of screening.
Okay.
Yeah, but in a cancerous biopsy sample, then the treatment will follow the cancer protocol.
Okay.
So surgery depends on whether the cancer is a small cancer, early breast cancer, locally advanced diagnosis, or advanced stage. So the different treatment, different stages will have different surgical approach and different treatment approach.
Actually, okay. So if a patient actually goes for a mammogram and you find a lump, in your experience, how many % of it is actually non-cancerous?
About 80% would be non-cancerous.
So there's only 20% chance that actually a lump is cancerous. Okay.
Most of the women who walk through our doors in breast cancer center, they're generally benign.
Okay. So only 20%. Okay. So
And it's often picked up through ultrasound, not so much with mammography.
Okay. So if a patient actually biopsy done prove that it's actually cancerous, okay, and, surgery is still the mainstay of treatment for cure and all for breast cancer. How do you decide actually which treatment options which will be the best for the patient? And some patient actually wants to do breast reconstruction on top of it, since we have a lot of plastic surgeons around which can actually mold the breast back to their normal size.
Okay, I would say the objective of treatment is to get a good oncological clearance, which means in simple English, you have to get rid of the cancer with a clear margin.
Yes.
So if, let's say, a patient comes with a lump in the breast and diagnosis is confirmed cancer, we will have to assess how big is the lump in relation to the breast size. We call it tumor breast ratio. So if, let's say, the tumor size is more than 30% of the breast ratio, so doing a lumpectomy may not be the best approach.
Okay.
So in this situation, we often discuss the other surgical option, which is mastectomy, which means removal of the whole breast. And when we offer mastectomy, we will talk about immediate reconstruction options, which is available in a lot of hospitals. If the patient doesn't want to go for mastectomy and still insists on preserving her breast, I would talk about downsizing the size of the lump by giving another mode of treatment, which means we give chemotherapy first. We try to shrink down the cancer. After complete 6 cycle of chemo, this treatment is called neoadjuvant approach. So you give chemo first, then surgery comes later. Most of the time, we will get good results with neoadjuvant chemotherapy, and most of the time, we are able to conserve the breast after a cycle of chemotherapy, 6 cycle of chemotherapy. There are caveats to this. If a woman comes in with multiple spots in the breast, but the cancer is not in one lump, in one area, but it's multiple areas in the breast. So if you look at the breast as the face of the clock, if they have cancer at 12 o'clock, 3 o'clock, or 8 o'clock direction, this is like involving all the areas. You can't preserve such breast even after a neoadjuvant chemotherapy. So for this subset of women, mastectomy is the best surgical approach, and we will explain to them. And a lot of the time, when you explain properly, they understand why things are done. Patients are very receptive to treatment.
Okay. So once you do a mastect, you can reconstruct the breast again? Immediately. How do you use? Do you use the patient's tissue? Use a prosthesis? What are the options?
Generally, when you want to achieve good cosmetic outcome, we will try to use patient's own tissue.
Okay.
So there are two types of reconstruction. One is using the muscle from the back or muscle from your abdominal, rectus abdominis muscle with fat over the anterior part of your abdomen. So if, let's say, the muscle that you take is not enough to achieve symmetry to the other side of your breast, then an implant is inserted to match the size. So in a simple word, kalau kata the patient is, we are using the fat from the tummy, you don't need an implant because it's enough to actually match your other side. But if you're taking the muscle from the back, which is an LD muscle, normally this part of the tissue is not enough. If you have a C cup or a D cup breast, so you need to compensate with an implant to match.
Okay. So what about like some patients who are like high risk of to get breast cancer, like those who are BRCA positive when you go for their screening test and all? Is our Malaysian population very receptive to have bilateral mastect, bilateral oophorectomy to remove the ovary so that they don't have cancer subsequently, like what Angelina Jolie actually did?
Okay. It's not easy to be told that you have cancer.
Yes.
And generally, when someone has breast cancer at young age, to tell them they have to talk about BRCA genetic testing is another hurdle that we have to go through. First, to diagnose cancer and explain to them that they have cancer, it takes a while for them to have this information sink in and accept. So generally, we will talk about further test, assessing risk factor, like germline mutation in our patient, but you need more than one counseling, or we say consultation session.
Yeah. So I think that's where we get our genetic counselor to come in.
Yes, to come in and also help us with the with the consultation. When a woman agrees to go for genetic testing, if the result comes back as BRCA germline mutation, we will tell them that the risk for getting bilateral breast cancer is higher in a lifetime. So when we do surgery for this group of women, it would be best to do it at the same time.
Okay.
But I would say not every woman is able to accept it. But generally, if they read more about this, and the younger generation, you'll be surprised. We have a lot of women who are more receptive to bilateral mastectomy and immediate recon. And the moment you offer immediate reconstruction, it opens up, they become more receptive. I mean, if you just talk about mastectomy, it's a mutilating surgery. It makes you feel that you're not a woman without your breast. But when you offer them something different, something to match back as what they have, without having the worry of having future cancer, they're more receptive to it. In fact, this morning I did one bilateral mastectomy with immediate recon.
Oh, that's good.
And she's not even BRCA, you know?
Oh, okay.
She's not even a BRCA mutation.
So why did she do a bilateral mastect? Was there 2 tumors? Or she was very afraid?
She only have one side tumor. But because her mom had breast cancer in her 80s,
okay.
She's in her late 40s. She doesn't want to worry about having problems on the other side. And she does have cysts and benign looking nodules on the contralateral breast. So she was telling me, if you can do this side, doctor, can I just do it at the same time?
Yeah. Actually,
and completely reduce your risk of getting recurrence.
A lot of my old patients will just say, potong, 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 potong. But the younger one will try to preserve as much as they can.
Yeah, but if you can potong, at the same time reconstruct, why not?
True.
Yeah.
I think it's something which carries the image of a woman. Okay, so these are actually for patients who are actually cancerous. What about, do you have any experience for patients who are non-cancerous, but they have BRCA risk, and they actually come to you to say, please remove my breast and my ovary?
It's a challenge still in this country.
Yes.
Okay. I'd say it's still a challenge.
I've never heard of anyone going through that.
I've had patients coming to for counseling on BRCA. They are germline with BRCA positive, but they are still undecided
Okay.
on the surgical approach. They're still not ready. They're still not ready, but we keep them on our radar. We make sure they come back for follow-up and checks.
Yeah, I just go for the routine checkups and all. Okay. So in Malaysia, right, is there any NGOs which you work with which can actually help our breast cancer patient? Because breast cancer patients, they have a lot of emotional roller coaster going on. So is there like a support group for them?
We engage a lot with BCWA, Breast Cancer Welfare Association. They come actually see all our patients in the ward. They give free consultation. They give free sharing session. We engage with them quite often. I would say almost all our breast cancer patients will get to speak to a survivor from BCWA.
Okay, that's good.
Yeah.
So that's for Klang Valley. What about like other
No, they
areas?
go all over the country.
Oh, it's all over Malaysia.
Yeah,
Okay.
it's not just in Klang Valley. They have their
So
own
that's good.
networking. Yeah, not only BCWA. There's a few others lah.
Okay.
Apa tu dekat offhand, I can't remember offhand.
Okay. No problem. So Dr. Saladina, is there anything you want to tell our viewers as a final say?
Don't be afraid to come forward for screening.
Okay.
Yeah. Even though screening doesn't prevent you from getting breast cancer, that's another mythos. People think when they come for screening, they will never get it. It's not true. Screening is for early detection. So don't be afraid to come for screening so that we can catch it early. So when you catch things early, treatment becomes a lot simpler. Curative rate becomes a lot higher. You live a lot longer. And in fact, you can live like normal life. You can even have like 15, 20 years is definitely within reach.
So another thing I always tell my patient, it saves your pocket also. Because
Certainly.
if you're diagnosed early, the treatment is lesser. When you're diagnosed late, your treatment is going to be a lot
more
targeted,
expensive.
and
A
all.
lot more expensive.
Yeah. Yes. Okay, so thank you, Dr. Saladina, for being in our show today. Thank you so much for coming.
The Bald Oncologist Podcast Series